I had a patient, and this patient has really impacted me a lot in terms of how I think of health inequities and bias. This patient was a young patient, around 25 or 26, and was HIV positive and really was struggling with the stigma of being Black, gay, and now with another medical problem besides his HIV. And many providers at that point said, there's nothing to do. This patient is not taking his HIV medication. What I did is sat by his bedside and said, I am Black and gay. I understand the stigmas. You've got to fight it. You've got to take these medications. Because if you take the medications, then we can get you what your heart needs, and you will be amazing. You'll live a long life. He cried for a long time, and he said, yes, Dr. Roswell, I will take my medications. It's cases like those that show me that when we have these biases, when we think about patients with certain identities, this is a time where we need to not abandon them.
Only 20% of a patient's wellness or well-being is dictated by the type of health care they receive. And 80% is determined by those social determinants of health, right? Where they live, their socioeconomic status.
In heart failure and cardiac transplantation, we truly have sobering findings. Black patients have the highest incidence, highest risk of development of heart failure. And unfortunately, in the last decade, the rise that we see amongst Black patients is far faster than any other race or ethnicity.
Everybody's access to medical care, medical services, primary care, insurance, whatever the case may be, is not equal. The playing field is very unlevel. So I think the biggest barrier to health equity is access.
Women, as well as underrepresented minorities, are quite underrepresented in cardiology, and even more so in cardiology clinical research.
I would look at the tables and it's just like, this trial made cardiac guidelines and it has no Black people.
The ACC is the professional home for most cardiologists, and ACC has a goal to really deliver the best cardiovascular care for patients. And in order to do that, we have to address health equity.
There should not be differences according to race, ethnicity, gender, sex, education level, income, according to affordability, according to the languages we speak, how we look. And I think overall, every human deserves the right to health and life.
In the mid-1980s, I stood up and gave a discussion at one of our annual meetings about disparities in cardiovascular care and outcomes in the VA population. And I talked about how people in underrepresented communities, especially African Americans, received inferior care. No one could believe it. The Credo program was one of our initial attempts at first understanding how the membership understood health equity. How did our membership embrace health equity principles and give us some guidelines about how do we best address our own professional community in dealing with health inequities.
Health equity is a moral imperative. We're seeing that it can be improved significantly by understanding what's driving inequities, understanding how to get inclusive care, and how to get us to deliver that care equitably.
We have always had health equity as part of one of our strategic goals. But honestly, till the year 2020, around the time of George Floyd's death, we really had not thought about how to actualize health equity for the college and its members.
My role on the task force ranged from helping out with defining what health equity was, working on health equity and implementing it throughout the college.
We came up with 3 goals. The first was to create a culture of health equity in cardiovascular medicine. The second was to prioritize health equity in all of ACC activities. And the third goal we came up with was to eliminate disparities by ensuring equitable cardiovascular care for all.
When we examined the opportunities that we had in the science domain, we recognized that there were numerous layers that we could intervene on, including cultural change, and making sure that all of our members and stakeholders would go through the implicit bias training, and that we would participate in this journey with a commitment.
We've done training on implicit bias, we've done training on microaggressions, and sort of understanding how you as a physician, where your role is in terms of interrupting microaggressions, creating an inclusive environment for patients. I think that really and truly launched the ACC in another dimension, another chapter, and enabled ACC to be a leader in healthcare delivery and transformation.
One of the other tangible ways that we can ensure health equity is to, really think about diverse clinical teams. Patients want to see physicians that look like them. So we launched a D&I initiative in the college in 2017.
Being in a program like this was kind of mind-blowing for me. I think it just goes back to my origins of being a first-generation everything. It felt like a weight was lifted from my shoulders. I felt like I didn't have to continue to kind of pave this way on my own. Like, I had a network and a system of people who were dedicated to helping me achieve my goals, whatever they could or would be.
Being part of the program now makes me feel like I am responsible to make a difference. I'm responsible to represent, and not only represent, but give a hand to the others that come, because there's so much talent that is being overseen. Sometimes you're like, oh, do I belong here? And the fact that I have mentors, sponsors within the discipline that I love, that are telling me, you belong here.
I went to an HBCU that didn't necessarily have a robust pre-medical program like other schools had, and exposure to this program allowed me to understand and visualize what it would be like to be in medicine and what it would be like to be involved in medicine in a positive way. If I wouldn't have experienced this program, then I may not have been in medicine today.
We have to be able to collaborate with all of our partners who share our vision at achieving health equity and social justice. And so we realize that this is a bigger problem than just the ACC can handle. But we are trying to forge those relationships that are going to help us to narrow that gap that exists as it relates particularly to cardiovascular medicine.
I pledge to take action to support ACC's health equity vision.
To achieve a culture of health where every person reaches
Their full cardiovascular health potential as a natural right.
I acknowledge the negative impact of
Cardiovascular health inequities on patient care delivery.
cardiovascular outcomes and population health.
I commit to work to transform my practice
And the cardiovascular care that I deliver.
To be the most equitable for all.